So this is the March edition of EMS Medicine Live. Apologize about February. The February break kind of took us all out of commission and couldn't find any presenters, so we took a month off and we're back for this month. I don't know about you, but it's been a very busy month for us between the holidays of St. Patrick's Day and Easter and all the things we do. It's been kind of hard to fit everything in. And there's one more thing that happened as far as Syracuse fans is Syracuse won the East Division and it's going to the Final Four, which is pretty remarkable. So we'll go orange for this presentation. Our apologies to Duke and Pittsburgh for that one. But EMS Medicine Live, myself, Derek Cooney, and Brian Clements here, the course directors. Obviously, we say every time, this is a presentation made for community and for academic EMS physicians, trying to share information, our experiences, and hopefully get you involved as well to get your perspective and involvement. I think everyone's now muted except for the two of us. If you have any questions, you can chat me, and we'll try to do that. And actually, I only have one computer today, so you can't chat. Just wait to the end, and we'll answer the questions at the end. This is being recorded. We will make this available to folks on multiple platforms. I'll show you at the end what those are. And, of course, questions at the end if you could. Today, we're lucky to have Chris Martin-Gill back as our first repeat speaker. He's a assistant professor at the University of Pittsburgh. Finished his fellowship, oh my God, several years ago now. Has been working there, both in emergency medicine, but also the associate director of the EMS fellowship, with Stat Medevac and pre-hospital care with the university. So with that, I'll give that to Chris.
All right. Well, thank you very much for having me again. Apologize for the technological issues, but seems to always grab me. Let's see if I can. Do I have control again?
Should. Try again.
Yep. All right. So Chris and I discussed a couple different topics, and we're actually due to talk about regionalization of emergency care in our EMS didactics. And so with me in our room, I have 5 distinguished emergency physicians here, EMS physicians I have with us. Ron Roth, Vince Macesso, 2 of our senior faculty members here, as well as Lenny Weiss, our current EMS fellow. Brian Marks, one of our very EMS-friendly residents here. And one of our colleagues from Saudi Arabia is working with us. So I have no conflicts of interest, at least not related to this. Always on look for opportunities to have conflicts of interest, so send them my way. We're going to talk about regionalization, and there's a number of slides here, and for anybody that wants to kind of like pause the video feed later on the recording and look at what all the references are, feel free to, and it's there for your benefit. But I'm going to use some just as a crutch to talk about a couple points. But the key things that I want to touch on are talking to some about the benefits and the challenges of regionalization, and specifically touch on what I call the past, the present, and the future of regionalized care. And we'll talk about really all of it is in the present, meaning that we're working on all of these aspects, but there's somewhat working really right now very actively, some that are pretty established, mainly trauma, and some that we really think are kind of on the horizon and not really potentially ready for prime time. So what is regionalization? It's the creation of a regional system of care that can manage medical conditions that either, 1, require resources not available off facilities, 2, have improved outcomes at specialized centers, or 3, are associated with costs that are better managed at some kind of a regional level or when you can share resources and those types of things. And so why would we ever want to regionalize? For that higher level of care, specialty services may not be available at other sites. And we understand this when we talk about, for example, trauma centers not having, neurosurgical capabilities at smaller sites, level 3 trauma centers, level 4 trauma centers, or non-trauma centers. Certainly I'm going to show you a number of studies that have looked at volume outcome relationships for many of these conditions. That's been proven for trauma, for post-cardiac arrest management, for STEMI care, for patients that need to go to a PCI center, And so there's pretty well established volume outcome relationships there. And so because we think that doing this will improve outcomes. Now, the issue that I'm going to come across is moving towards taking patients to the ivory tower. But anybody know what ivory tower that is from?
Never Ending Story.
The Never Ending Story. Very good. 1984. Great movie. Love that one. But that's the ivory tower there. As we call Presbyterian Hospital here in Pittsburgh is our, #1 ivory tower. And I know in Syracuse and elsewhere, you have the one where they all come flocking to. And it turns out that there's on-call shortages, and so even in those facilities where you may have a hand surgeon, you're just only going to have them available 3 days a week or something, or certainly not at night. And so sometimes this regionalization of care happens not because it's a service not provided at a hospital, but because it's just not available all the time. And we need this to be an increasing issue with specialist coverage. There's economies of scale. There's issue about reimbursement of care that really became an issue for trauma centers and why it allowed trauma centers to exist. Community hospitals realized that a lot of folks that have trauma don't have health insurance, at least initially, or otherwise weren't seeking care on their own. Trauma just happened to them. And so they had bad reimbursement for their care. And so they said, sure, you want to set up these trauma centers? They're going to take all these trauma patients away from us. That's no skin off our back. Now, you just go ahead and do that. Obviously, that became a burden for the trauma centers, and so some of the legislation and reimbursement and other things changed to actually be able to reimburse that care for trauma centers. But that was one of the things that helped lead that. And so there's regionalization in other industries. So just to provide some examples, Coca-Cola, Walmart, Amazon, all of these kind of big shops that have figured out that instead of having individual shops and all the supplies at individual places, if you actually create the big warehouse, the one place that everybody goes to and kind of things farm out from there, those economies of scale that we can learn from other industries. And so we know about regionalization and disaster management. So, it's very often that you can't have, an MCI unit at every single EMS agency. And so disaster management often ends up being a regionalized type of medicine. This is a picture of Carolinas Med 1. It's a deployable hospital. I understand they built kind of in the initial iteration about 4 of them across the country, and others got developed after that. Cost of $4 million, 2 ORI beds, ICUs. And then when you fully deploy it, including a big tent kind of canopy, turns into a 130-bed field hospital. It's been deployed at hurricanes and other such situations. You can imagine you're not going to have this in every city. And so it's going to end up being a regional or state or multi-state asset that you would have available. So we understand already in EMS regionalization of management, different things. Some conditions we won't recognize or regionalize medicine are things like poison centers. So in this diagram, the solid red circle, which is, I guess it's a little bit harder to see, the solid red and kind of the star lighter colored red circle. The solid red circle are places that have poison centers for that state. And if you look at like Montana and Idaho and Wyoming and Nevada, you'll see that there's not actually a poison center in those states. Like the entire state does not have a poison center. And they receive their poison center support from neighboring states that cover those areas. For some of these states, maybe the Dakotas, it makes sense because just of volume, it isn't enough to have their own poison center. But you realize that having those unified resources and regionalizing that makes sense in that environment. This is our Mr. Yuck here from our poison center in Pittsburgh that actually manages from here, we manage the poison centers for Pittsburgh, or actually for the Pittsburgh region and West Virginia. And pediatric care is also regionalized, and we know about that, and we accept that. Really sick pediatric patient, a special needs patient, things, we're going to send those to those hospitals. So we're very familiar with regionalized cares for a number of specialty things, but there's a lot of things we've been working on in EMS to regionalize care for specific acute care conditions. So let's talk a little bit about some of those. I'm going to call trauma the past of regionalized care. If nothing else, let's just call it established, because it's the one I think that everybody takes for granted and is clearly established. So if you get shot in the chest 2 blocks from a community hospital. An ambulance is going to pick you up, drive away from the hospital, and go to a trauma center. And I think that we can all agree that that's accepted. It's what happens. Nobody would question that. You know, the community hospital wouldn't question that. The EMS providers wouldn't question that. They can even convince the patient very clearly about they need to go to a trauma center. But if you had the same conversation about, hey, you're having a STEMI, or hey, you're having a stroke and we need to go to this other hospital, it's a whole different conversation. And so that's why I'm talking about trauma as the past, because it's established, and it's been established now with initial development back really in the Vietnam War. So it was the Korean War that, you know, medical helicopters kind of started. In the Vietnam War, these systems of care started to be implemented on the battlefield. And I'm highlighting a couple of papers for any EMS fellows or fellows in training out there that are key documents you need to know about for the board exam. But accidental death and disability, a white paper that basically said that our, especially trauma care, but our EMS care in the United States is terrible. It's better if you get shot in a battlefield at Vietnam, you'll get better care than if you get hit by a car in one of U.S. highways. And so then you start having some development where about that same year, the Federal Highway Safety Act promoted uniform guidelines for EMS. And then finally in '73, some money came around to develop these EMS systems. But it was a bunch of that stuff going on. But then actually the very early document, Early Cure of the Injured Patient in '72 from the American College of Surgeons. That was the first manual that would tell people how to manage trauma in a systematic way. So that was the building block publication for what would turn into ATLS. And that first ATLS course came in 1980 as an official ATLS. But the roots of that were back in the early '70s. And so, you know, kind of speeding up with another 2 decades of work being done in the trauma arena, we're left with the trauma centers of today. These happen to be just the ones that are here in Pittsburgh. We have 3 level 1 adult trauma centers, as well as a children's pediatric or level 1 trauma center as well. And obviously in your neighborhood, you're going to have a variety of trauma systems, level 1, level 2, and other level trauma centers. Now, do trauma centers actually improve care? You know, I do a whole different talk just on trauma centers and trauma triage and, you know, getting the right patients to the trauma center and all that. But just a couple of kind of systematic review articles to mention. The one by Selson in 2006, 15% reduction in mortality in favor of a trauma system. Mostly talking, these studies in the past have compared bunching level 1 and level 2 trauma centers with non-trauma centers. And so if you take trauma patients to level trauma centers, they do better than if they go to non-trauma centers. There's been less study actually looking at level 1 versus level 2 trauma centers and any difference in outcomes there. Another review article from Lansing looking at a bunch of articles showing reduced mortality. Other folks have looked at the question about whether it's beneficial to be transported directly to the trauma center or if you could go indirectly, meaning you show up at a community hospital, you get shot in your chest, you go 2 blocks, you're at that community hospital, and then they do whatever supportive care needs to happen, and then you're transferred to that level trauma center to receive continued care. This was one study looking at patients with traumatic brain injury in direct transport with associated with a 50% lower mortality than indirect transport. And similar studies have shown the same thing to be with other major trauma. And so the summary on trauma is basically that, you know, there are improved outcomes if you go to level 1 or level 2 trauma centers if you're actually traumatized. So if you sprain your ankle and you're flown to a trauma center, you're not going to be better than if you go to a non-trauma center. So we are talking about patients with major trauma, and that triage question is for another conversation. But the concept about regionalized care for trauma has been proven for major traumatic injuries as well as TBI, and transporting them directly from the field is better than not. And so if that's the past, or something that's very well established, then what are we working on right now? And so you might say that STEMI care is also pretty well established, but I think in most EMS systems, it's an area of continued work. And the way that we regionalize this care in the United States continues to be an area of active work. And so kind of to set the mood here, we know that there's a huge amount of death that happens from acute coronary syndrome, PCI has improved mortality compared to thrombolytics when given within the reasonable time window. STEMI care is time dependent. The early studies showing that there is a 2% reduction in mortality for every 30 minutes of time savings that you can accomplish. And most of that was looking at door-to-balloon times. Now, there was the JAMA paper that came out a couple of years ago that looked at how much time we've saved since we started worrying about this, and has mortality changed. And the time savings really was in the neighborhood of like 15 to 20 minutes of door-to-balloon time when you looked at the aggregate time savings. And they didn't find a mortality benefit for that. So that's kind of in agreement with what we thought to begin with. You'd need a 30-minute time savings to impact mortality. So if the only outcome that you're looking at for ACS, where treated ACS has a mortality of about 4%, is really going to take a significant time savings to notice an impact. But really not looking at other things, other outcomes like incidence of congestive heart failure, the total myocardial salvage, other symptoms related to MI, functional capabilities and things that happen after an MI. And so other scholars have kind of argued that that mortality outcome is maybe not the only one we should be looking at. And so the American College of Cardiology has continued, and the American Heart Association have continued to put a significant emphasis on time intervals. And initially that time interval was a door-to-balloon time of less than 90 minutes. And so we developed systemized care for STEMI patients going directly to PCI-capable facility. Folks arguing that most of the U.S. does live within an hour of STEMI facilities, so there's no reason that we should send them anywhere else. Of course, the challenge is knowing which ones are having a STEMI and getting them there in the right way. And actually, on that prior slide from the Nalamoth article from 2005, they looked at door in, door out times, door-to-balloon times and such, and they realized that the system door-to-balloon time ends up being about 3 hours on average. So very often, door-to-balloon times can be an hour and a half to 2 hours in places don't have a regionalized system of care where community hospitals can very quickly ship somebody out. And so we recognize that you're not going to be able to meet those metrics like you would if the patient had come directly to that STEMI center. And so other folks have argued about, which places should be receiving these patients. The biggest argument I know we've had in this region, as occurred in other regions, is whether going to a STEMI or a PCI facility that does not have cardiothoracic surgery backup, whether that's appropriate or not, and whether there are better outcomes there. Because, if suddenly there's a perforation of coronary artery, or if you spray the left main and you recognize that you have 3-vessel disease and they're not going to be amenable to PCI, they really need cabbage, and so they're throwing in a balloon pump, trying to quickly ship that person over to get a cabbage, and maybe that patient's unstable because they have 3-vessel disease and a major STEMI. And what are you doing to patients? Taking them somewhere that there's no cardiothoracic surgery available. And so some folks did some studies specifically to look at that. The major one that looked at that was the Seaport trial. The first kind of major publishing of that was in 2002 in JAMA. And they looked at 11 community hospitals that had no CT surgery available but could do PCI. And the study was aimed to look at, so the patient got here and they're having a STEMI. Should we go ahead and cath them here, or should we give them thrombolytics and then kind of send them somewhere else for rescue or things like that? So which one's safer if you just go ahead and cath them here even though we don't have a CT surgeon with whatever complications that may be, or if we go ahead and give them thrombolytics? And they showed improvement in outcomes if they went ahead and did PCI. So whatever adverse events might occur, whatever low incidence of cases where they had to be referred for CT surgery or where they had a complication they couldn't deal with, was less than the margin they had of benefit by providing PCI instead of thrombolytics acutely for those. So that was the first trial that kind of led to the development of PCI centers that are just by necessity not going to, or by lack of specialist availability, are just not going to have CT surgery 24/7 available. And we have a few of those here in Pittsburgh area. And then the follow-up study for that was a non-inferiority trial that the same group published in the New England Journal 2012, where they basically looked at PCI which was all PCI, not just STEMIs, performed at facilities that had CT surgery backup or that did not have CT surgery backup. It was powered as a non-inferiority trial. They actually had a lot of patients. There were thousands and thousands of patients in this trial. And they showed basically that it was non-inferior. So this provided the argument for being able to do even elective PCI at facilities that do not have CT surgery capabilities. However, there was this other literature, and this is kind of the biggest papers that came out of this. There have been a number of kind of smaller papers that have provided the same arguments. I'm just bringing out for you the kind of the most important literature. But this Weinberg study, but from 2004, looked at hundreds of hospitals and whether patients were treated at PCI centers with or without CT surgery available. And they realized that the patients were more likely to die if they were treated at PCI centers without CT surgery available than if they were treated at centers that did have CT surgery available. So that just kind of contradicts this whole CPOR concept of it's okay to do this at places that don't have CT surgery. If when you look at the mortality of getting it done at one place versus the other, it's worse mortality at the places that don't have CT surgery available. And so that has led many folks to continue to latch onto the concept of taking patients directly to places that have CT surgery, regardless of whether they're credentialed and authorized to do emergent PCI through the CPOR trial or through other mechanisms. But what they found out in this study is that increase in mortality was primarily a volume relationship. And they realized that it wasn't so much that it was the CT surgeon saving all those lives. It was the fact that that was just a marker for larger volume facilities. So one of the things that I started our conversation with today was about the volume outcome relationship that exists with a lot of these conditions. And it turns out that this is one of the key ones. So centers that perform more than 50 PCIs per year actually have improved mortality compared to folks or centers that do not. And so when you look at, for example, Pennsylvania's requirements for PCI centers, to be able to do elective PCIs, you have to meet that 50 caths per year volume requirement. So we have a couple of facilities here in our area that do not have CT surgery available, that are STEMI facilities that you can take a STEMI patient to and do a cath, that are elective PCI intervention facilities as well. And our statewide requirements are that they meet a number of different requirements just for PCI centers, but specifically the volume relationship, so that they have to do at least 50 procedures. And in some cases, they actually have volume relationships per provider that have been outlined. So I would argue that STEMI centers have to do more with more than just whether you have PCI available. One key thing is about whether you have an integrated system with pre-hospital 12 leads and being able to do early activation in the cath lab. Prior studies on this looked at 15 to 30-minute time savings when we do cath lab activations from the field. Here in Pittsburgh, I'm very active in doing QI for our 6 STEMI receiving centers in southwestern PA. And so I literally look at every single STEMI case, which is kind of interesting. But what I found is that even when we get a command console in the parking lot of the hospital, and they're talking to us as they're going, doc, I'm at the hospital, I got a STEMI, it's right, it's a STEMI, beep, and you're backing up and like, why don't you just go in and let the doc take a look at that, and they'll activate the cath lab. Well, if we make the decision as the command facility to activate the cath lab at that point in care, you actually, on average, save about 15 minutes. So you'd think about, they're like already physically at the hospital. They have arrived. You're making that decision as a command physician and activating the system processes. On average, you save about 15 minutes because almost invariably it takes the doc to come over. They may repeat their 12 lead. The doc may at least look at the EMS 12 lead and make a decision based on that. And so at the shortest, it's an extra 5, maybe 10 minutes. At the longest, sometimes we get delayed 20, 25 minutes while they're repeating a 12 lead and then making their own phone calls. So I am a big proponent that if it's clearly a STEMI, even if you're literally outside the door, you've already taken the history, you've already determined that that needs to happen, and we need to activate the STEMI Center then. And so volume facilities associated with outcomes has been also published in a number of other publications of importance there. And so some folks back a number of years ago proposed criteria for what some would term a level 1 heart attack center. This may not be every single STEMI center that has now propped up, which at least it seems like they prop up everywhere. There's just like everybody has a cath lab these days. Not only 24/7, but having that cardiothoracic surgery backup, but very importantly, some concrete PCI numbers. So greater than 200 procedures per year, when 36 of them STEMI. So 3 a month, basically, is what they're looking at there. And then 75 PCI patients per year per interventionalist, which is actually pretty significant numbers. But at our major centers, this happens routinely. Our providers are doing this all the time, and we have certainly these capabilities that are at their major centers, but that really hasn't taken off. And it hasn't taken off so much because there are a lot of economic considerations to trying to regionalize the STEMI care, and why a lot of community hospitals has decided, hey, we can get cardiologists to come in and do it, and they can do it safely, and they can do it well, and and it's the right thing to do. And there's certainly a financial incentive to do those at the community hospital, where the patient gets their usual care and where they can keep the patient, provide continued care for those patients. And so there's been a big proliferation of units. And not just that, but a big concept that I think has impacted the community hospitals is that when EMS providers are trying to make that decision about where to take their next cardiac patient, odds are it's not a STEMI patient. But the concept of going to a cardiac hospital versus a non-cardiac hospital can influence the transport of quite a number of other chest pain patients. And so even the $20,000 cath lab, management that you might miss out isn't even that big of a deal. It's the other 100 patients with chest pain that required overnight observation, stress tests, and all of that other care to find out that they had pulmonary embolisms, they had CHF, they had aortic dissections, they had other things that needed surgery and other care. All of that would be potential substantial loss in revenue. And so it becomes very important for hospitals to be able to capture some of that market. And money is just has to be part of the conversation. If you're trying to work within your EMS system, in your hospital system, and try to figure out how you can influence patients going to the right place at the right time and work within your environment, you just have to have all of these thoughts in mind, because it will influence the people that you're interacting with. And so in 2013 was the latest comprehensive American College of Cardiology and American Heart Association guidelines for STEMI management. And so a big thing that came out, a big support for this that was already being actually emphasized back in about 2010 was this concept of sending patients for primary PCI with a first medical contact to device time of less than or equal to 90 minutes. You get 120 minutes if you have to do an interfacility transfer, just because otherwise nobody could meet the goal. But really it's the concept of 90 minutes. And that 90 minutes comes from the thrombolytic data. So at 120 minutes, providing thrombolysis is equivalent to PCI. In recognizing that you'd have a goal door-to-needle time of 30 minutes, the time at which PCI benefits over thrombolytics is 90 minutes. And so to be able to get the improved mortality that we see with PCI, which is time-dependent, over just giving somebody thrombolytics, that cutoff would happen at a first medical contact to device time of 90 minutes. So that's how they came out with that specific number. And it's class 1 level of evidence A. It's as strong of a recommendation as you can provide with the strongest level of evidence to support it. And so this is what most of us are working on these days. So STEMI systems are in existence. Many people would say that it's very well established. I think that's established in a variable way when you really look at comparing EMS systems in different areas and the way that hospital networks work in different areas. It's very important to have an integrated system with EMS that can make pre-hospital activation occur. This issue of volume-based criteria is really still in question, but even under the regulations of certain states like Pennsylvania, at least to be able to do emergent PCI, to be able to do elective PCI, though that volume criteria is not the same, just to be able to do an emergent case. And like trauma and stroke, we need standardized protocols and quality improvement and stuff. Post-cardiac arrest care, I'll talk very briefly about. Basically, it's another thing that could benefit from regionalized care. So there's been a number of studies that have basically shown that survival after cardiac arrest can vary substantially hospital to hospital. We know in the Pittsburgh region from our own data that even within our metropolitan system, survival post-cardiac arrest varies between 25% and over 40% for patients that come into the hospital with a pulse. That's substantial. So if you're the consumer, if you're the patient, and EMS is asking themselves where you should take the patient, if you right up front and say, would you like to go to the hospital where survival for you, now that you have a pulse is 25%, or do you want to go to the hospital where survival for you now that you have a pulse, is 45%? And we don't look at it that way, but there is that variability, and those numbers are consistent year to year. And so folks had said, well, what components of that is it that matters, that maybe some hospitals are better than others? One thing is the availability of PCI and actually performing PCI in an emergent fashion for most post-cardiac arrest patients. I think the landmark study on this, which was never really reproduced in the same way, was the Spalding paper from 1997, where they basically just cath all cardiac arrests immediately, right away, and they just took them just to see what it looked like, just to see, let's just take everybody immediately to the cath lab and let's see what we find. And they basically found that more than two-thirds, almost three-fourths of them had significant coronary disease, and about half of them had coronary occlusions. So just like by a number needed to treat concept, the vast majority of these have significant coronary disease, and half of them have an occlusion that would need to be corrected, as the culprit lesion causing their MI. And it turned out that with a five-fold odds ratio, successful angioplasty was an independent predictor of survival with post-cardiac arrest. So I call this a landmark study because they were the first one to kind of do this. This was kind of crazy talk when they were doing, this concept that we take patients to a cath lab right away, cardiac arrest. That's just, a lot of them are going to die. Why are we going to take them to the cath lab? And now it's become standard of care, at least at many of our higher level centers. And one of the studies here from Reynolds, one of our colleagues, had shown now a twofold outcome of death between cath and good outcome, and that association occurring even when the cath did not result in a procedure being performed, in a stent being performed. So it turns out that our colleagues have found that when you cath somebody post-cardiac arrest, it does something that is impacted with outcomes. Like there's something that happens that more of them survive. Like even if you take the subset that didn't get a stent and you compare the ones that got cathed early versus the ones that didn't get cathed early, the ones that got cathed early and didn't get any intervention at the cath actually do better than the ones that didn't get cathed. And there's actually a lot of reasonable reasons why that happens. One is that you're not just looking at the culprit lesion, you're rapidly assessing people's ejection fraction. Maybe they end up on a balloon pump or some other intervention. Maybe you're assessing, other global heart function issues. You're assessing for their need for a pacemaker or other things. Just getting the cardiologist to be aggressive early on and involved in doing procedures on these patients can lead to those other things that happen earlier on in care of patients that may be what actually impacts the outcomes. And so a big component for kind of regionalized post-cardiac arrest centers has become the 24/7 availability of PCI. And that's one of the two main criteria that has been suggested as a requirement for a post-cardiac arrest center. The other one is the ability or the concept of having standardized protocols for care of these patients. Those protocols involving things like targeted temperature management, and how we manage that. Not only that, but when you how you prognosticate these patients, and when would you continue their cure versus decide about withdrawing support, recognizing these days that you really have to wait 72 hours before you start to make decisions. And what we think about the difference in survival at some of these other places is that, they may not have standardized protocols for this in place. And if you're not awake within 24 hours, they're talking to a family about pulling the plug. We know that a subset of those will suddenly wake up at about the 72-hour mark. And so we can't pull things back too quickly. And so some studies, including our own colleague John Rittenberger, published before and after implementation of protocols, standardized protocols for post-cardiac arrest care, showing substantial improvement in good outcomes after the institution of standardized protocols with targeted temperature management and everything else, even our own major institutions. So Brendan Carr out in University of Pennsylvania has published on this as well, mainly looking at other factors that impact care. Large hospitals, urban teaching hospitals, again, the volume outcome relationship, similar to PCI, showing some arbitrary difference in 50 versus, over 50 versus less than 50 cardiac arrest patients managed per year being associated with outcomes. Certainly there's probably nothing magical about that 50 mark. But that's what they had looked at, comparing hospitals with more than 50 cases versus those just less than 20 cases. And so we know that outcome relationship to be true for cardiac arrest care. And so there are a number of different areas there that have actually designated post-cardiac arrest receiving centers, Arizona being one of the first ones to do that. FDNY in New York, from my understanding, actually basically saying we're not going to transport post-cardiac arrest patients to any but this list of hospitals. Here in southwestern Pennsylvania, what we call our EMSI region, which is a 10-county region of southwestern PA, we instituted a list of hospitals that have PCI capabilities, standardized protocols that can do targeted temperature management for management of these patients. And we have that list available online for all of our EMS providers to follow in terms of destination selection for our cardiac arrest patients. Of course, then we've got next-gen cure cardiac arrest. If you're not really resuscitating within the first 10 minutes, maybe you're putting on mechanical CPR, maybe you're driving fast and getting them to a place that can do ECMO rapidly, and you're getting them quickly to that cath lab to open up that coronary artery, and you end up with the whole concept of extracorporeal life support, which is kind of the next evolution of regionalized cardiac arrest care. We're working on that here in Pittsburgh at our flagship hospital, UPMC Presbyterian, where we're already have in place an ECMO machine in the emergency department capable of being instituted right away. We have our perfusionists are on site 24/7. In fact, I think there are 2 perfusionists in the hospital at any given time, 24/7. We have a list of critical care physicians and now interventional cardiologists and some ED physicians that would all be able to put in the pipes for starting ECMO in the ED. And so we're in the last stages of making an integrated protocol for very select cases of out-of-hospital cardiac arrest that may benefit from this instead of continued care in the field when initial resuscitation efforts are not being successful. So that's kind of the next stage of post-cardiac arrest management. But we recognize that the capabilities need to be more than just PCI and being able to do hypothermia, but having standardized protocols. There's probably some volume outcome criteria that we need to think about. And so I think this continues to be refined, but maybe a little bit less in the literature more recently than what we had seen maybe 5 years ago. Acute stroke is an area that we're actively working on these days. A lot of big revolution happening, particularly over the past 2 years, I'm sure you're aware of, worthy of its own separate talk. Starting in 1995, we started to have TPA be available, and we thought that had better outcomes for patients after debating it for about 20 years. And so, 10 years after that, we start the establishment of primary stroke centers, having very rigorous criteria and being identified of what their capabilities need to be. with the thought that you're going to have improved efficiency of care if you actually designate places and they have standing protocols and get to the CAT scanner quickly and make sure that TPA is delivered if the patient's eligible, and all those types of things happen. You're going to improve care, and that was the concept, which was actually borne out in the literature. So this was a study from New York City hospitals, 32 of them, where they basically compared outcomes between hospitals that had that were stroke facilities versus non-designated hospitals within that system of a total of 32 hospitals. And they identified basically faster treatment times, time to TPA, and all of the procedural outcomes became better, even if they weren't specifically looking at a patient-centered outcome. They're all looking at procedural outcomes. But certainly things happen faster if you have a system in place that can manage it better. In parallel, as our primary stroke centers were being implemented, interventions started happening. In '99, you have the PROACT 2 study, where they basically showed that giving intra-arterial TPA within 6 hours can resolve symptoms of stroke better than placebo, which was the first way that it was compared. And then in the early 2000s, you have a series of 3 trials. The biggest one was IMS-3, with the other ones listed there, that started looking at the combination of performing intra-arterial therapy or some of the actually clot retrievers or stent retrievers that were available at the time, and what their impact on care was. And basically what they figured out was that if you treat somebody that's eligible for TPA with TPA versus treat them with half-dose TPA, and then you take them to get some intra-arterial TPA an hour later, or in about 25% of cases actually do a thrombectomy, those 2 groups of patients do the same. Okay, and this actually really kind of burst the bubble of interventional stroke physicians, though at the same time was really informing them about how we might refine the way into whom we perform these interventions. And so the whole concept of endovascular therapy continued, and you have the first comprehensive stroke centers in 2012. And those comprehensive stroke centers can not only give IVTPA, but they can have, they have advanced neuroimaging capabilities. They have dedicated neuro ICUs, which is actually a significant roadblock for hospitals that want to become comprehensive facilities. The other roadblock is that comprehensive centers have criteria not just for the management of ischemic strokes, but of subarachnoid hemorrhages. You actually have to have a certain number of coilings of those to qualify. But in any case, you have these places that started to go into existence. And so the question for EMS on the regionalization front becomes, where do I take my patient? I have these primary stroke centers. I just sat through this lecture from this whiz-bang interventionalist that told me all about their comprehensive center. Which one should I go to? And that's where the question is today about how we manage this. And I know that this looks very differently across EMS systems, maybe some of the ones that we're talking to today. So early on, the benefits of comprehensive stroke centers that were supported actually had to do with rehab. So while IMS-3 and the Mr. Rescue trial and all those were basically downplaying the benefit of endovascular therapy, folks were upplaying the benefit of all of the comprehensive care, so that rigorous protocols, the volume-based criteria, or relationship to outcomes, but especially it was the dedicated stroke rehab services that substantially were related to improved outcomes. And so that became the initial reason why folks were trying to shuttle patients to certain larger facilities. But then in January of 2015, everything kind of changed in stroke care, I think. And from January to June of 2015, we have these 5 articles that if you haven't talked about them at your shop yet, you're behind the times. I'm sorry. And so I won't go into these because you've already read them. But starting with the Mr. Clean trial and including a few of them, including the Revascat trial that Tudor Joven here at Pitt led, we actually participated in Escape, Revascat, and Swift Prime here at UPMC. and really showing the benefits of endovascular therapy when you select patients that have large vessel occlusions, when you treat them at a time that they still have a large area of brain at risk with a small core of already dead tissue, and when you're trying to get them to that endovascular therapy quickly, so without as much of the delays that were occurring in the earlier trials. And so those showed substantial benefit to those patients, actually a number needed to treat between 3 and 7, consistently shown across those trials. And what are the procedures that are currently being done? Well, it turns out that nobody does intraarterial TPA anymore. I mean, that's, a pretty harsh statement, but we just had a journal club on a couple of these papers, and our head interventionalist, Tutor Jobin, like I said, led one of those trials. I asked him point blank, I said, Tutor, how many intraarterial TPA cases do you have anymore? Which was the basis for most of those trials. 75% of IMS3 and the Mr. Rescue trials and all those actually was intraarterial TPA. He said 0 cases. That is just not the way that we're managing these cases. Patients get IV TPA if they're eligible for it, and then they go to endovascular therapy. And when they get endovascular therapy, they get one of 2 things. They get this tiny little suction catheter in there, and they suck the clot out, which is pretty cool. The other thing that's even cooler is they have these stent retriever devices, which were different from the first generation devices that I showed a little picture of before. They actually go inside the clot in this little tube. When the tube gets withdrawn, the stent expands, and then they pull the stent with the entire clot back out. And those actually are the ones that have been shown to have substantial improvement in outcomes. And additionally, data showing that for every 30-minute delay in opening that blood vessel, you lose 10% of the benefit of good outcomes. So when you look at patients, the benefit of modified Rankin scales that you have on these patients, for every 30-minute delay that we have to getting in the vascular therapy, you're losing 10% of that benefit. They're really emphasizing this timing need. And in fact, the International Stroke Conference, one of the major international stroke conferences, just happened in the past month. And they basically said that the number one topic of conversation among the stroke docs was EMS. And how does EMS play a role in integrated stroke care in that regionalized system of care for stroke patients to get them to the right place at the right time? And so that question that I showed you of, do I go left to a primary stroke center or do I go right to a comprehensive stroke center, is really in the minds of a lot of people right now. And in fact, in 2015, the American Heart Association, American Stroke Association gave focused update with recommendations that said, if patients are eligible for IV TPA, they should get it, but patients should receive endovascular therapy if within certain time of onset, depending on the degree of deficit, depending on if they have a large vessel occlusion, and the sooner we provide those interventions, the better. What we've done here in Southwestern PA is develop some regional recommendations. We said we're not going to bypass those primary stroke centers if you're a TPA candidate. So we're going to take you to a primary stroke center to get TPA on as quickly as we can. But if you're outside that window, then we have our EMS providers consult medical command physician and see if the patient likely has a large vessel occlusion or not. If they do have a large vessel occlusion and they're within a 12-hour window, then we will have those patients go to the equivalent of a comprehensive stroke center because they're potentially a candidate for endovascular procedure. The question is how you define that large vessel occlusion, and so we locally have defined that as an NIH stroke scale of 8 or greater. Actually, our critical care air medical providers with Stat Medevac actually perform NIH stroke scales in the field, so those are the ones that are using that. In our race score, the race score is being implemented across our EMS region right now to be used by ground providers because it's a more simplified scale. If you're not familiar with the race score, it comes from Barcelona, Spain. It was both designed and validated there. We're looking at our own validation project here. And it basically is a simplified scoring system based on the NIH stroke scale where it has 6 data elements to it and can help to identify a large vessel occlusion with a reasonable sensitivity and specificity. They initially published in their paper a 5 or greater as having an optimal sensitivity and specificity, as you can see in the diagram there. Their newer literature, the Barcelona guys are actually purporting now, but haven't published yet, is actually a 4, maybe better when they've looked at it. We've validated this in our air medical literature in a 3, which is actually more predictive. Now, obviously, that's a biased sample of patients that ended up in a helicopter. But you can, what I take from that is be mindful of what number you pick in your EMS system, and you should try to have a system in place to identify how that or any other score that you're using performs at identifying patients that have large vessel occlusions, or actually get the therapies that you're sending those patients to a specialized center for. So in summary, for stroke care right now, we continue to emphasize, all those times that primary stroke centers have been emphasizing for a while. But the key right now is trying to figure out systems of care and regionalized care for patients that may be endovascular candidates to be identified by EMS providers in the field, utilizing that EKG for stroke, which we're currently are implementing the RACE score for that, in trying to figure out how we effectively get these patients to the appropriate facility without stealing all of the stroke patients in the region that are better served at other community hospitals, and particularly without delaying the initiation of thrombolysis where it could be delivered if they just had gone to the closer place. So to finish in the last couple of minutes here, what is the future of regionalization of acute care? Well, I think the next frontier is sepsis and other critical care. And for the same reasons as I've told you for all these other acute care conditions, there may be some benefit to regionalized care for these conditions. These are, we see time-sensitive, time-intensive in terms of their care, resource-intensive, but also time-sensitive conditions that can benefit from protocols, from specialized training and equipment and capabilities. And so people have published on regionalized care for critical care, a lot of reasons to do it. Only about 10% of ICUs are staffed with in-house intensivists. There's a lot of community hospitals that have an ICU, that they call it an ICU. I'm thinking of one right now. I don't want to say the name, but it's a 2-bed ICU that looks a whole lot like a monitored floor, and it's managed by the hospitalist group, and it's just a whole different kind of environment than in our ICUs, where we've got liver ICUs and left lung ICUs and right lung ICUs. I mean, it gets crazy, but really specialized facilities. And so the volume outcome criteria and other things have also been shown to be better. But critical care is less defined than trauma, stroke, and other conditions. And so suddenly you have a substantial reduction in revenue of other hospitals. It can put a strain on families. As we say in Pittsburgh, having to actually cross a river to get to the hospital is a big deal versus going to that hospital on the other side of the river, whereas where you usually go to, and puts a lot of strains. And so for this to be successful, you really have to have an interconnected system of hospitals, whether it's within your own health system or outside, which really the model that probably would work best but is the hardest to achieve is where you have a feedback system of patients, where maybe you bring in the hospitals into the major hospitals during the acute care of certain patients and then send them back to the community hospitals for the ongoing care or maybe the rehab care of hospitals. So you can regionalize the acute management of those patients. And so as we think about things as EMS providers and how do we send patients to hospitals, is it okay to go to that big center all the time? Well, maybe, but those places should also have systems in place so that they don't get overcrowded, and so they can also feed back some of those patients back out to the community as a reverse triage type of a mechanism that makes the entire health system sustainable. What about sepsis? Well, very quickly, it turns out sepsis is quite common. You see this graph, which I think is a little crazy, the number of sepsis cases brought in by EMS providers. I think this is a recognition issue. I think we're just becoming better able to identify sepsis as time goes on. But you can see that if I spend all this time talking about acute myocardial infarction and stroke, well, EMS providers see a whole lot more, severe sepsis cases. With sepsis 3, I should change that slide. There's no longer severe sepsis, right? You're either septic or you're not. Or you're either in septic shock or you're not. But that's how that was defined before. And so it turns out that, there's a 3% increase in odds of death for each hour delay in antibiotic administration. Certainly we hate to have, requirements in our EDs about some magic 3-hour or 4-hour window about when antibiotics should be administered. But there is a time relationship there. And so How do we improve treatment delays? Well, this starts with the EMS arrival, and just like we've done for STEMI care, as is shown up top, we might do field triage for sepsis care down at the bottom. And if we have systems where we can identify those patients early, maybe we start treatment early, or maybe we activate hospital processes to improve the care that happens. But it's challenging to identify those patients. You know, some of the publications that have been published before have talked about looking at temperature and other vital sign management or vital sign assessments to identify these patients in the field. But it turns out that it's actually challenging to manage to measure an accurate temperature in the field. Paramedic knowledge and awareness about sepsis is currently lacking. That's why I call it part of the on the horizon topics for us to talk about. And the ease of determining these things when you're calculating a score based on a complex algorithm of vital signs and things may be complicated for somebody to do on the fly. We've also been studying the use of biomarkers in the field. Currently have collected data, actually blood samples on 432 patients in the field, looking at cytokines, lactate, procalcitonin, and troponin, and other things, currently analyzing that data, and we'll hopefully have that published for folks to look at in the near future, and maybe coming out with the next lactate meter for some biomarker or series of biomarkers that can help identify these patients in the field. And, you know, is not only identifying these patients in the field, but what we've shown is that the pre-hospital treatment for these patients actually reduces their mortality. So even just the fact of looking at whether somebody got IV fluids in the field or not, or even have IV catheter placement, maybe it's just the expedited care that occurs when you're taking somebody seriously and you do that. Even when you fully adjust for other patient factors, just those simple pre-hospital interventions seem to be at least tied to mortality. But, you know, the issue is we need more tools. We need more tools for regionalized care. We need maybe lactate meters to be actually something you can purchase. Tissue oximetry we've studied before, other things that might regionalize care for things not just sepsis, or maybe even having an app that you would look at to identify some of these patients. So this is one that we have under development right now, where you hit a button, you say, I think my patient might have sepsis. And it goes through a list of different questions. Do you think your patient has an infection? What are their vital signs? You input some things. And it gives you a score, a validated score, in the end that says this person is at high risk of sepsis. What hospital are you going to? I'm going to UPMC Presbyterian. Okay, an alert has been sent. And we would actually activate a sepsis alert in the hospital for you to get an early evaluation, for folks to maybe have a different way of thinking about things, to initiate early resuscitative care and early antibiotics when appropriate for those patients and hopefully impact. So yes, sepsis alerts are coming, like trauma alerts and stroke alerts and other alerts that we have. And we're certainly looking at implementing something like that here as part of our regionalized care of sepsis. So thanks for sticking through all that. Basically, I talked about a number of different conditions, acute care conditions, some like trauma that have been very well established. Nobody would ever question somebody going to a trauma facility. Some that we actively are working on right now that are definitely established, like STEMI care and stroke care, but others really coming in the horizon. Sepsis, critical care, things that are more nebulous and a little bit more challenging to try to regionalize. But things that we aim to improve in the future.
Good. I'll unmute everyone if they have questions. I have one question first. For the pipeline trial, are you measuring lactate pre-hospital? Is that what you said?
Yeah, we actually drew blood and measured a point of care lactate level.
What are you? What's your point of care lactate measurement device?
We use the lactate pros that are no longer being manufactured. The first version. I think we stole all of the ones that are in existence off of eBay, and we are not shy about that. And if you have some, we'll buy them from you. Just send me an email. I'll pay good money. We've used them in a number of trials. So we've published probably half a dozen papers on lactate measurements in the field for trauma, for for sepsis, for just acute care. And yeah, the issue is that there's no point-of-care lactate meter that is CLIA waived right now that is available for purchase by EMS. The Lactate Pro 2 exists, but the company does not want to go through the cost and time consumption to get it CLIA waived by the FDA.
I know we've looked at, Rural Metro or AMR, whatever it is these days, looked at buying the non-CLIA waived lactate devices. We haven't got them yet, but we're thought about just using them as a screening test and see if they help with sepsis alerts or not. But so I think I figured out where all the Lactate Pros went. So I appreciate that.
Yeah. We all of our all stat medevac, all 17 helicopter bases, we have lactate meters on all of them. They're used every day.
Excellent.
We use them for trauma and shock. They're used all the time. So we've actually moved all of our research lactate meters are now in clinical use for that center. And what we're looking at next is looking at the iStats, so non-CLIA wave devices that you have to basically, create your own lab and do your own calibration and things like that, or have a system in place to do it through a hospital. There is a lactate meter out there that I think they're trying to sell for about $3,000. It's just a lactate meter. But yeah, you'd think somebody could just go back to a basic device and get it FDA approved, but it doesn't exist yet.
All right, fair enough. Let's see, everyone's unmuted. Any questions from in Pittsburgh or from the group listening? I'll take that as a no. Just want to remind everyone who's watching this now or in the future, you can pull up our past presentations from our website at Upstate. We have a EMS Medicine webpage that's separate from Upstate. You can find as well. Of course, we're on Facebook and YouTube. Follow any of these links and you can find all of our past presentations. And remind folks for next month, we have Dan O'Donnell from Indiana University presenting a pediatric mass casualty case. And we have folks from across the country coming up. We still have July and December open. I'm still looking for presenters. If you know anyone, please let us know, or we'll fill in. So with that, thank you for attending, and I thank Chris for presenting that. That's an excellent presentation, and I appreciate the time you took for that. Thank you.
All right. Thank you all.